here. But before we start on that, we have with us one very distinguished clinician scientist, Professor Dr. Sandeep Jain from the University of Illinois, Chicago. He's a fabulous clinician scientist, and his pioneering research on the role of nets on the ocular surface of refractory dry eye disease has paved way for the targeted approach therapy in dry eye disease here. So here he's going to talk to us on something which is evolving, on something which we are still understanding. And I think his talk will enlighten us more on the novel therapies for treating dry eye disease. Over to you, Dr. Sandeep.
Thank you, Vanati. Thank you for inviting me over here to this wonderful session being attended by, I can count 1,000. I come from US Trump land, so 1,000 people I can see over here. I'll be talking to you about work that we have done and that has led to us saying that the work that we're doing could be developed into therapies, and we developed a good amount of data supporting that position. Before I start, most of what I'll talk is intellectual property is protected by University of Illinois at Chicago, and it's licensed to various commercial entities. The idea is to develop, so obviously this is going to happen. But what I will talk to you is about the new thought process that we are having in treating some severe conditions, so I can put you all out of business who put a patch graft or who do various surgeries that you're going to talk over here. If you can treat the cornea and these inflammations, ocular GVHD, Sjogren's syndrome, severe OCP, Stevens-Johnson's, with just eye drops and therapeutics, well, a lot of us would be unemployed pretty soon, won't we? But the idea is to help patients so that you can treat these really severe dry eye disease with new therapies and with new agents that can help the surface. I think this is a very important concept, and conceptually when we were making this diagram, it really clarified a lot of things for me. One thing that I realized over the years is that there is no single drug that can take care of these inflammatory ocular surface diseases, because there are multiple inflammatory pathways that are simultaneously active in dry eye disease. That's key. And that also by default means that the best therapy to control the surface inflammation and surface disease is inherently going to be a combinatorial therapy, because one agent cannot do it. And I think it's kind of a dream to say that let's just use one drug, or for drug companies to say that, or for us to say one is better than the other. You just need a whole lot of treatment to help each other. But what are the pathways that are involved? I think that's key in appreciating what type of treatments one can use. The classic pathway of antigen-presenting cells going to local lymphoid tissues and then migrating back to the surface of the eye and causing Th1 and Th17 inflammation that is induced by interferon gamma and IL-17, that's the classic pathway. That's why you use cyclosporin to inhibit T-cell hyperplasia. It does nothing more than that. That's all it does. Doesn't kill T cells, doesn't stop its migration. So if you have systemic diseases where T cells are migrating to the surface of the eye, it won't work, and that's another problem, that there are autoreactive T and B cells in various diseases that are also present on the surface of the eye. Another thing that we discovered was that there are neutrophils on the surface of the eye which spread their DNA material onto the surface of the eye as a spider web, and which is called neutrophil extracellular trap. It is extracellular DNA web that is decorated with some very highly inflammatory molecules, and it's really one of the reasons I think which explains surface disease, especially in ocular GVHD and eyes that are really red hot. Then there are post-translational modifications that can happen once you have all this biological material on the surface, leading to autoantibody formation, complement activation, and various other things, dendritic cells producing cytokines and chemokines. I could spend a whole day on this slide, but I won't. I'll move on to show you what we feel very wrongly and mistakenly, that these are just mucus that sticks to the surface of the eye in these patients. It's not. It's not just mucin. It is an inflammatory mess of epithelial cells, neutrophils, nets, and various other inflammatory products. And we've shown that by doing immunolocalization and showing that these are nets. So these things that float around in the eye of these patients are not just mucus. You can't just irrigate it out. You have to treat that by various anti-inflammatory agents. So what can we do? Nets, their backbone is extracellular DNA, so we need to disintegrate that. We can use an enzyme-based approach with DNase eye drops, or a charge-based dismantling approach with heparin eye drops. And regarding heparin, using low-dose heparin from AIMS, Dr. Sharma Namrata Sharma just published an article in Ocular Surface, and I'm a collaborator on that paper, where we show that this works in Stevens-Johnson syndrome as an adjuvant drop. But DNase eye drop, and I'm not telling you anything that is hypothetical. In our pharmacy, compounding pharmacy, everything that I tell you is dispensed. So patients receive that today. It's not sometimes in future. And yes, there is development going on to bring it to the market, but we are using it. We did a clinical trial, showed that there is significant reduction in corneal signs and symptoms with DNase, a second clinical trial in ocular GVHD patients. And this drug is now in phase 2 clinical trials, would be in phase 2 clinical trials pretty soon. All the GLP talks and pre-IND expectations from FDA have been met, and the IND filing is expected soon. It's been licensed to a commercial entity, but we are on the way to getting it to the market. The second thing that I showed, so DNase is one, get rid of the nets. Second is, well, once you have all these proteins on the surface of the eye, a single amino acid change happens. It's just the way life works. Arginine is changed to citrulline, and that one amino acid change, the body thinks that this is a foreign protein and launches a whole immune response against it, producing autoantibodies, anti-citrullinated, against those proteins that are exposed. Why the eye does that? The eye can produce a whole immune response, and the complete immune response by itself doesn't need the rest of the body, and that's why it is possible for the eye to produce these autoantibodies. And we showed that in many publications, that immune globulins are there on the surface of the eye. They are present in great amounts, and to counteract that, we can use intravenous immune globulin eye drops, which has multiple actions against autoantibodies on the surface of the eye. We are using it right now in our clinics, and we have shown in clinical trials that it reduces signs and symptoms of these patients. This IND was filed just this last month in March, and phase 2 clinical trials, first in human, is going to start in July 2025. We are on our way on this one. Now, one thing that I'm going to also tell you about is autologous serum tears. We all use it in severe ocular surface disease, but there are issues with it, logistical issues. We all know that if there is severe rheumatoid arthritis, Sjogren's syndrome, PUK, it's a good idea. But what do you do if you look in the serum and find that a lot of inflammatory cytokines are high? Would you give this patient autologous serum tears? I won't. At least I'll be hesitant. Another patient with Sjogren's syndrome and rheumatoid arthritis, this cornea is very messed up. You want to give serum tears, but this patient doesn't have a peripheral venous access. What do you do? And there are many, and she had IL-6 and IL-8 also high in the serum, and there are many other patients with anemia, on chemotherapies, and so on. And you can't just give these patients autologous serum tear. And what we have come up with is that allogenic pooled human plasma tears are a good substitute. Octoplas is available commercially. We use that currently. It's not ideal. We are trying to make a more ideal formulation of pooled human plasma, which is in the works. And it's very good because they can get it from pharmacies, and the shelf life is going to be longer. The patient doesn't have to go get a blood draw and and all the things that come with it, the logistical nightmares. And this formulation that I'm talking about is going to be made such that it is ideal for dry eye patients in terms of no inflammatory material and high levels of growth factors. And this is future. We are on the way for this. We have been invited by NIH, not NIH, ARPA-H, they have more money than NIH, to go down this road of development. This is a multifunctional, multi-institutional initiative where we are developing a continuous system for monitoring and response and responsive therapeutics called C-SMART, which is implantable devices. Basically, what they have is a sensor system and a biobank, a biological factory that you can fine-tune to produce anything, but there is a continuous sensing of biomarkers in the tears based on which there is a release of drug from these biofactories, and they come from the upper puncta. The lower puncta is the sensoring mechanism connected with a Wi-Fi device to the AI system, which continuously monitors this. This is very futuristic and requires huge amount of miniaturization. Will require probably, so we are thinking next 4 years, maybe more time than that. But this is the future of ophthalmology, that you are, and it's not hypothetical. This is happening, and this is happening now because all the people that are working on this project, leaders in their field, respective field of miniaturization, AI, continuous biosensing, and the biological factories that I'm talking about, they all exist. And it's just putting them together and making it happen. So what I've just told you are things that have come from our effort at UIC, the various drugs that I told you that are dispensed through our pharmacy. Combinatorial therapies are the way that we are treating these patients using DNase, IVIG, autologous serum tears, sometimes potentiated with vitamin A. So we give them 10 tablets of vitamin A at 9 p.m. and then they draw the blood at 9 a.m. so that the vitamin A levels in the blood is higher. And it helps, especially in Stevens-Johnson's and keratinizing disorders, we've seen that to really help a lot. So hopefully we'll get some of these therapies in your hands in the near future.
Thank you, Dr. Sandeep Jain. I think that was a good insight into all the newer therapies for dry eye disease, and we look forward to hearing more about the progress in these. Thank you so much. So we will now move on to our vast. Any questions to Dr. Sandeep as Dr. Lomi is setting up his talk?
No, we looked at the levels of nerve growth factor. Nerve growth factor in autologous serum tears is not much. The growth factors that are of any significance are HGF and IGF. But you want to give 100% at that time then, because you don't want to dilute it. The problem is not in neurotrophic. The problem is in Sjogren's, or the problem is in Sjogren's typically, and the problem is in other patients who have systemic disease. Somebody is getting an antibody drug conjugate that is messing up the whole limbus and causing conjunctivalization, has the antibody drug conjugate for cancer treatment in their blood. You're not going to give autologous serum to them. So that's the problem, that these patients who have neurotrophic, if just that, that's okay.
A lot of these factors can be taken care of when we're talking about...
Mike, please come to the mic.
Would you have any comments about use of PRGF instead of the autologous serum drops?
So PRGF we use very frequently in our practice, and my experience with that is that some patients love it, and I know theoretically they have growth factors and so on, but leave the theory aside. From a practical experience, it is that I find that for majority of the patients, I would say 80%, maybe more, I cannot tell the difference between PRGF and 100% autologous serum or 50% autologous serum. I think they pretty much give me the same benefit. PRGF is more expensive and so on. But some people love it, and I don't know why. Some patients with corneal neuropathic pain love it. So they say, well, they become much better. They come with some theoretical risks of neovascularization that you could stimulate if you use PRGF just because of the growth factors and VEGF that might be there. So you have to factor that in.
There in your autoserum tears as well, but yes, the concentration is far more in PRGF.
It's far more in PRGF, exactly. So I think I would not use it as a first line. I would still use 100% autologous serum if I really have to blast them with something, even neurotrophic or any other indication for that matter. And if it doesn't work, then I think it's pretty reasonable to say, well, let's try PRGF before we do anything else.
Thank you so much.
Thank you. And